Thank you for the organizers, and thank you for Rosh. Can you hear me well, Dr. Amal?
Yes, we can. Go ahead, please.
Okay. So I was asked to present a case from our practice. So this is my agenda. We'll do a small introduction, go over our standards at King Faisal Riyadh, and then do the case presentation. So as you know, non-Hodgkin lymphoma is a frequent malignancy. And in the kingdom, it was the third malignancy in males and number 6 in females, according to Saudi Cancer Registry 2020. The median age was 50 in males and 53 in females, and it did constitute around 5.4% of all cancers among Saudi nationals, and the total number was around 756 cases. At King Faisal, this is our numbers for 40 years, 45 years actually. And as you see here, non-Hodgkin lymphoma is the fourth cancer we see. We've seen around 7,700 cases all over these years. And here you see the age distribution with the majority of patients between the age of 30 and 69. This is how the distribution is according to the age. As you see, the majority are between the age 25 and 59. And this is how these patients presented. And as you see, the metastatic cases or stage 3 and 4 are the majority, constituting 54% of the cases we've seen. And this is around 4,031 cases. So for early stage diffuse large B-cell lymphoma, we usually treat these patients with abbreviated R-CHOP unless they have bulky disease. So all early cases will get R-CHOP 3 cycles. We do a PET. If the PET is negative, we give a 4th cycle. If the PET is positive, then we extend that to 6 cycles, and we may use radiation according to the location. For bulky early stage, we do 6 R-CHOP and radiation still. For advanced stage, as you've heard, we have too many options trying to beat the standard R-CHOP. Standard R-CHOP still a standard. It was challenged by the POLARIX trial recently with a PFS benefit in the POLARIX trial, but still a good standard. And we do use R-CHOP at King Faisal. We're trying to approve Pola-R-CHP for a specific subgroup of patients, those with IPI, high IPI. We don't do radiation a lot in advanced stage diffuse large. We restricted to patients with bone involvement, extranodal involvement, and for any persistent area on the interim scan. For older and frail patients, we substitute doxorubicin by gemcitabine or liposomal doxo or etoposide, and frequently we do mini-CHOP. And if the patient is very frail, sometimes we do CVP or BTK inhibitor with rituximab. So this is the case I wanted to share. So this is a 69-year-old lady admitted in a local hospital in the north part of the kingdom in April 2024. She was admitted with abdominal pain. She has hypertension, diabetes. CT showed many intra-abdominal and retroperitoneal lymph nodes and biliary obstruction. So they placed a stent, started her on antibiotics, and sent her to King Faisal. She was ECOG 4 and she had a lower extremity weakness on presentation. So we got urgent PET and MRI. And as you see here, the PET, she has many extranodal involvement. As you see, thyroid, both kidneys are full of disease. She has lymph nodes. She has the pancreas is involved, as well as the stomach and a paraspinal lesion pushing on the nerves. So this is the colored part of the PET scan. As you see here, the thyroid involvement. Here's the paravertebral mass. It's actually pushing on the nerve and invading the bone. Here you can see the kidneys and the pancreas involved, and here more you can see the pancreas involvement. So a lot of extranodal disease. So we did a biopsy urgently, started her on steroid and consulted radiation. She was started on radiation actually after securing the biopsy. for cord compression pathway. And then the biopsy later on from the right iliac bone came back as high-grade B-cell lymphoma, not otherwise specified. So she had diffuse CD20 lymphocytes, Ki-67 around 80%, and was consistent with aggressive malignant B-cell lymphoma. The FISH failed, unfortunately, because it's a bone sample, so they couldn't run it. So she received radiation to T68, 20 gray and 5 fractions. Then we did CNS evaluation, we did MRI, we did CSF, both were negative. So summarizing her case, we labeled her as stage 4BE because she's had B symptoms and a lot of extranodal disease, large B-cell lymphoma. If you check her IPI, she was of the older age and advanced stage, poor performance, LD was elevated, and she had extranodal involvement, so she gets 5 points. And her CNS IPI, she gets 6 points because she has many extranodal and she has kidney involvement as well. We gave her first cycle RCVP because she was in very bad shape. She recovered very well after 1 cycle, besides her lower extremity weakness. And she was discussed on tumor board for dose adjusted R-epoch or CHOP-like therapy. And because of her age and performance, dose adjusted R-epoch was not selected. And we thought CHOP-like therapy will be not enough for her case, given her risk status and her extent of her disease. So we chose to go for Pola-R-CHP starting from the 2nd cycle with ITs, as she has very high CNS IPI. So this is again her presenting PET scan, and here you see her interim scanning. She's in remission, and the end of therapy PET, she's in remission. If you notice here, she has some uptake subcutaneous, and this turned out to be pressure ulcer development because of her lower extremity weakness and her inability to move around. So basically, she went into remission with the Pola-R-CHP and ITs after 6 cycles. Now, as you know, many of these new drugs are coming into the practice in combination with CHOP or CHOP-like combination. So we have Glofit Pola-R-CHP versus Pola-R-CHP, and this may beat the current standard and becomes a standard. We have Epocrutamab Pola-R-CHP versus Pola-R-CHP, the NHL L5 trial. Also, this may establish a new standard. We have CAR T-cell actually in front line. So there is the Zuma 23 comparing axi-cell versus R-CHOP or dose adjusted R-epoch. And then we have even more, CAR T-cell use, and this is the Alpha-3 trial. So this trial is running in patient with MRD positive post R-CHOP. So patient with MRD positivity will be randomized to this CAR T-cell versus observation, and the MRD is being tested by cell-free DNA. So a lot of new options. Of course, we'll have to balance risk and benefit. So not always the best choice for your patient, but these are options coming over and may change the practice. And of course, we have to think about the financial toxicity, like using CAR T-cell in the front line or for MRD positivity. Both trials are expected to be positive, actually, but then the financial toxicity has to be considered. With this, I will finish and happy to take questions. Thank you.